Welcome. Welcome, everyone. Do we have folks joining us? I can't tell from my shared screen.
I don't see anyone new here yet.
I see
Okay.
folks joining.
Oh,
Okay,
yes.
welcome. All right. Welcome, everyone. Looks like we have a great group here. Nice to see some familiar faces. Um, really excited for this discussion today. So we're going to get started. We have a lot to get through over the next hour. Everybody is on mute, but don't worry, there'll be time for Q&A, and we'll be basically in discussion most of this next hour. So we really hope that you can engage with us in this conversation. So welcome to the CIN webinar, Building Processes to Improve SDOH Data Capture, Coding, and Referrals. As I said, we'll engage in a discussion around improving social determinants of health data capture, coding, and referrals, including how Bay Area Community Health, a federally qualified health center in the Bay Area, captures patient SDOH data through MyChart and other mechanisms. My name is Marie Hubbard, and I'm the Senior Program Manager for the California Improvement Network, also known as CIN. CIN is a learning and action community that advances equitable healthcare experiences and outcomes for Californians through cross-sector connections, spreading good ideas, and implementing improvements. CIN is a project of the California Healthcare Foundation and managed by Health Force Center at UCSF. You can learn more about our organizations by visiting our websites. So as I mentioned, you all are on Zoom, as well as on mute. But we do encourage you to jump in, raise your hand, ask questions as we go through our discussion, and there'll sort of be time at the end of our hour to open it up to all of you. So stay engaged, think about what you want to learn from this conversation, and don't hesitate to ask. So now I'm really excited to introduce our speakers. We have Khushdeep Grewal, Dr. Khushdeep Grewal, Medical Director at Community Health Center Network, Jenna Lunger, who's the Director of Clinical Operations at Bay Area Community Health, and Dr. Reema Menezes, Medical Director and Family Medicine Physician at Bay Area Community Health. So really excited to be a part of this conversation today. I am just going to stop sharing my screen and want to just really start our conversation talking with Kush from Community Health Center Network and wanting to just learn a bit more on the background on social determinants of health data capture, coding, and referrals at Community Health Center Network. So Kush, can you share a bit about Community Health Center Network, both who you are, what you do, and how Community Health Center and Community Health Center Network's background and experience with SDOH data capture, coding, and referrals?
Yeah, thanks. So the Community Health Center Network, it's a consortium of 8 federally qualified health centers in Alameda County and in Northern California. And we provide a few different services to our member health centers. One, we're a managed services organization. So we, do things like utilization management. We provide, kind of like financial advocacy assistance to the health centers. And then also we have a pay for performance program. So we do have like a financial part of what we provide. The other half of what we do is sort of advocacy in general, like advocating for increased funding for the clinics and making sure that we sort of support them in providing or being the safety net for Alameda County. We also do a lot of quality work. like providing assistance to the clinics and measuring quality and, making sure we have like adequate resources to provide quality work. So social determinants of health, we felt affected all of these services of Community Health Center Network. We were looking at our pay for performance, and we realized that um, it can be somewhat difficult to provide the same levels of quality care to our patients depending on what social determinants of health they're experiencing. And we realized that we don't have a great way of kind of risk stratifying our clinics based on the complexity of the social complexity of their patients. We looked at data around like homelessness, around food insecurity, and we realized that there's a lot of missingness. There's also just a lot of missingness regarding basic things like ethnicity, language, immigration status. So, all of these things that we know affect our patients' health. So that was one of the drivers. Like we realized that we can't really develop a risk stratified P for P. We can't really help our clinics enter this like sort of new era of value-based care without having like a good idea of well, um, how complex is the patient population. So that was one of the drivers for us to become interested in social determinants. The other thing, and I think just kind of personally, anyone who's been a provider, I'm sure there's many people who are here. Um, it's I've had many patients who've come in for, diabetes follow-up, and diabetes follow-up in someone who, speaks English, is employed, has good transportation, has good family support, is able to cook most of their meals at home, um, is very different from someone who, for example, I had a woman who, was experiencing domestic violence at home, was illiterate, relied on public transportation, and, could not, like, she didn't have papers to be employed and get, support, for the community supports that can help you manage your diabetes. So those two visits were starkly different, but when you look at your schedule, they're given the same amount of time, and it never ended up being the same amount of time. And it leads to like a lot of like moral injury and burnout among providers. And we're trying to not necessarily make it easier to work in an FQHC, but to kind of acknowledge how difficult it is and to try to provide support where it's needed. So that was another thing. I think just coming from this as like a personal, like, I really want to provide good care to my patients. I felt like it was important for us to work on getting a better idea of how complex they are.
Yeah, absolutely. It's really important to understand the complexity of patients in order to really provide the right care, better care, quality care. Um, so when you think about your member health centers, can you just talk a little bit about why it's important to engage your member health centers in SDOH capture? And where are they now in that process?
Yeah. I mean, it is important to get engagement because right now there is no, I mean, if we haven't provided good incentives for the health centers to do this work. Like essentially, we're asking them to ask some very personal, involved questions of their patients, to take time away from limited visits to take this to get this data. But what is the incentive for them to do this beyond just providing good patient care and doing the right thing by their patients, which they do. Like this isn't like to say that they don't do it without incentive, but um, if we truly are going to say that social determinants of health matter, then we need to sort of incentivize. So with community health worker benefits and everything, there's like and CBO involvement. There is small benefits that we could provide to the health centers, and um, but I think this is a topic that we kind of want to say, like, if we have this information, maybe we can advocate better for you to actually be compensated for this work that you do. But yeah, it is something that we really do have to get consensus on, and we have to do convincing to say, like, you need to take resources away from other things and put into here. So the health centers are at different places. I think, Dr. Menezes and Jenna, like y'all have done a fabulous job. Like out of all 8 health centers, BACH is the one that, has done the most. Like there is sort of like a process of information intake. There is like looking at the information, and then there is like a referral process. And so it feels like all 3 of those have to be in place for this to be a meaningful interaction for the patient and the provider, because you don't want to leave a provider with like some like very like delicate, complicated information and just be like, okay, well, that's good to know. I don't really know that I can help you with this. So I think BACH has done a lot to kind of fill in that like other part of like, well, what do you do when you have that information? I think the fact that all patients are sort of receiving these social determinants of health screenings is also another huge step that BACH has taken that I think is really important. Other health centers are using things like Prepare and Epic to gather social determinants of health data, but it's on specific patients. So it'll be on patients who are enrolled in behavioral health care, or patients who qualify for enhanced case management just based on utilization or chronic conditions. So like specific sets of patients will receive the screening, but I think we sort of like social determinants of health, like the learning is that it affects all of our patients, and so the fact that we're able to do it for everybody at BACH is a huge step forward as well. Some of our health centers are sort of doing like very basic, like like gathering data on homelessness, and that's sort of the extent that they have the resources and staff to work with. So I think we're on a continuum, and we hopefully will be able to like gather some learnings from BACH and from other health centers that are a little bit more advanced, and like kind of bring it back to the health centers who are not doing it, to kind of say, well, these are the benefits. This is like, like what our patients are saying and our providers are saying. And so maybe this is something that you could invest in.
Yeah. Great. Well, thank you so much, Kush, for setting the foundation. Part of this work was funded by the California Improvement Network to really drive your understanding of your member health centers' data capture and to better support them in their SDOH data capture, coding, and referrals. So really excited now to bring in your member health center, Bay Area Community Health, or BACH, to just talk a little bit about the work that they did, that they were doing and did as part of this project. And they're really in the beginning stages of SDOH implementation, and have made, as you mentioned, Kush, have made significant progress on designing effective workflows for SDOH data capture, coding, and referrals. So I am really excited to welcome Jenna and Reema from BACH to join this conversation. Jenna and Reema, let's just start with hearing a little bit about BACH, or Bay Area Community Health, and how BACH got involved in this project with CHCN.
Absolutely. Thanks, Marie. And for those who don't know, and by the way, thank you for this opportunity uh, for us to highlight the work that we've been doing at Bay Area Community Health. And for those who don't know, Bay Area Community Health is a federally qualified health center in Northern California, and our service area stretches from the Lower East Bay to South Bay, and we serve around 100,000 patients annually. We uh, our mission is to deliver exceptional health and social services that improve quality of life for the individuals, families, and the communities we serve. So, to align with our mission, we at BACH had been screening even for many years um, uh, at-risk population. So we do have a behavioral health social services department, and within that department, we have teams like the Enhanced Care Management, ECM team. We have a substance use disorder MAT team. We have also our HIV care team. We have community health workers who had been screening for social determinants of health, and they had been connecting patients to resources. However, we did not have a standard to screen all of the patients because, as you know, and as Kush mentioned earlier, that we realized that there are unmet social needs for all patients, and one of the impetus for BACH to start doing this was that our providers and our care teams needed support when patients were asking for resources for social needs. And as a clinician myself, I have encountered patients who ask for resources, for transportation, for food, and we actually did not have a referral in place to connect those patients to resources. So the first thing that BACH did was have a referral in Epic that providers could use to refer any patients who ask for resources and connect. And we at the time we did not have a lot of in-clinic community health workers. We only had community health workers who were supporting certain programs. So in the meantime, we used our behavioral health care coordinators to help connect some of these patients, who were asking for resources. We also, with CalAIM initiative, there was a huge emphasis on social determinants of health screening. And, a couple of years ago, we also collaborated with the Alameda County Recipe for Health program. And it is a program that adopts the food as medicine model that integrates food-based interventions to address chronic conditions and address food insecurity in patients. So we did pilot this program in one of our clinics a couple of years ago. So our staff and providers did get some training on why SDOH screening is important and how it correlates to improved health outcomes. And of course, so that was one of the first steps that we took as an organization to start screening, even though it was just one domain, which is food insecurity. But our MAs were trained in pending referrals for providers, entering Z codes. So we started, with that initial step. And as an organization, we always are looking for projects to improve health equity. We have worked, with NAC on a Million Hearts initiative to improve heart health and blood pressure control in vulnerable patients. And we focused on our African American patients where, our compliance was below, the average population at BACH. So when this project, was offered by CHCN to improve screenings using Prepare tool, we really jumped on it because we wanted to expand our work, and so that was one of the it was one of the stimulus and driving factors for us to expand our work that we have done. And then, we did have meetings, interdepartmental meetings even before to plan on some of the SDOH, how we could improve SDOH screening and integrate into Epic. Our staff, our CHWs were using Find Help, previously known as Ann Bertha, but it wasn't integrated into Epic. They were having to browse a separate website, and it was a little difficult, and it wasn't a tool that all of our staff were familiar with. So the MAs did not know about it. Some of our LVNs, RNs, and other community health workers, who do CCM were not very familiar with the tool. So we made an extra effort to also integrate Find Help into Epic, even before we started working on the CIN grant. So that's how we got started on our effort to do universally screen our patients for SDOH.
That's fantastic. Yeah, and we'll talk a little bit about referrals through Find Help a little later in this conversation. But you did mention the Prepare tool, which is the tool that you used and chose to use for capturing SDOH data through MyChart and other mechanisms. So can you just talk a little bit about why you chose that tool and kind of how that process works?
Sure. So the tool that we use, we are using the Prepare tool, which is embedded in Epic. We were very clear that we wanted for all the screening data to flow directly into Epic, and so it's easy for everyone to view, and for the referrals to be placed after reviewing the data. So currently we use so there are multiple screening tools, and even in Epic there is another tool called SDOH domain. So this tool includes the core domains, of Prepare. It draws heavily from the Prepare framework, but it also there are a couple of supplemental domains that it has, including social isolation, relationship safety, and physical activity. So we were very clear that we wanted a screening tool that integrates well, and where we have an ease of data capture. So that's why we went with the standard tool that OCHIN offered, which adapts the Prepare framework.
Fantastic. Can you just talk a little bit about how BACH worked with OCHIN to map the DHCS prioritized Z codes and kind of how that works?
Absolutely. So initially, when we started brainstorming about our workflow, I have to say it was a marathon, not a sprint, because it took us a while to develop a good workflow from start to finish. So we had done a lot of work with Find Help. So we had the latter part of the workflow ready, and then the screening. Once we decided on the screening tool, we had our IS team, did work with OCHIN to place a JIRA to help with. So what we wanted was, we wanted something that, in addition to the screening flowing into Epic, we also wanted something more, which would help alert the providers and the staff that a screening has been completed. Because when we started, we initially started with our front desk screening on welcome tablets. So the screening was available on our welcome tablets, and we actually thought it would be good to have concurrent screenings. So we, as in clinic, we also have other screenings, for depression, for substance use. We follow an integrated behavioral health model, and we also screen for pediatric ACEs, a lot of other things. So the front desk was assigned to administer the screenings in the beginning, because they are able to see that a patient is due for it on their DAR report. And when however, we did face some challenges because the screenings were not being administered consistently. So we modified our workflow, a bit, but how we actually started was we worked with Ocean Epic as a part of our universal SDOH screening project to have Epic customize an alert for us on the storyboard, which pops up whenever a screening is complete. So in addition to the in-clinic screenings, we also had patients completed on MyChart prior to their appointment. So there were two ways. So either the patient could complete the screening on MyChart, or they could complete it in clinic when they were due if the front desk sees that the patient is due and they administer the tablet to the patient. And after the screening is complete, there is, and if it's positive, there is a pop-up alert that we customized for BACH that shows up on the storyboard. And that is a cue for the MEAs to know that the screening is positive, and they would pend the referral for providers for social services. Uh, uh, we also actually before the custom in addition to the custom alert, we also were working with Ocean to map to adopt the to customize the Z codes to match the SDOH domains. However, we lucked out that Ocean Epic adopted the DHCH prioritized Z codes for SDOH screening for all health centers across our collaborative. So right now, what the workflow we follow is that after screening is complete, through Ocean Epic, we have a BPA alert. So in addition to the storyboard alert that is customized for BARC, we also have a best practice advisory, which automatically shows us the Z codes that we could populate in the visit diagnosis section. And so providers are able to do it. The MEs found that a little complicated to use the BPA. So we later developed a cheat sheet for the MEs with some of the Z codes that they could enter. And but it's teamwork. It's not just the providers. It starts from the front desk. And then, of course, if the screening is positive, there is an alert that pops up on the storyboard. The ME looks at the alert, and then they use their cheat sheet to enter the codes and also pen the referrals for the providers. In case the ME misses, pending the referral, if the provider sees that there is a alert on the storyboard, the provider can also go to the PPA and then enter those codes and refer the patients to social services. So we have, right now we have been piloting it with just 2 providers at one site, and it's just been 1 month. But we have had success in screenings being completed while the patient is waiting for the provider to step in. And initially we were a little skeptical and nervous about if the patients would accept filling out such a long questionnaire, or if the providers we would have buy-in from the staff and the providers. But so far I think we have been doing well with 2 providers and at one site, and slowly we plan to scale it to and roll it out to the other providers at that one site in hopes that we could improve our screening rates.
Yeah. Yeah, that's wonderful. It gets back to kind of what Kush was talking about at the beginning, really all about, how do we understand the complex needs of our patients and not just understand them, but do something about it. And so, having those alerts built in and having those workflows set up so that it's the screening's happening, but then, the support is also happening.
Exactly. And Marie, at this point, I would like to share my screen to
Yeah,
show the workflow that we created, if that's okay.
absolutely.
So as you can see, this is our workflow. So the first step is to administer the prepare screening. So this is the DAR, which is the department appointment resource. where the front can see that the screening is due, and they administer the tablets to the patient, and the patient completes it. So we were doing the prepare, but now we are doing all SDOH domains. And once the patient completes it, there is a BPA alert that pops up, and the Z codes, can be added from the BPA section, from the plan section by the providers to the visit diagnosis. The MAs could also do this, but they found it a little bit complicated. So we have a cheat sheet for them. So this is on the storyboard, there are icons that light up once the patient completes the screening. So green is, negative, yellow is positive screen. And when it's grayed out, it means that they either skipped it or, the screening wasn't offered. And this is the storyboard alert that pops up once if there is any positive screening. So in this case, there was a positive screen. So that's the storyboard. And this we customized for BACH. The BPAs for all of our all the health centers in our collaborative, OCHIN collaborative. And then once that alert pops up, the MAs are able to send the referral, which is right here, to social services, and they use their cheat sheet. And after the referral to social services is signed off by the provider, the social services community health workers use the Find Help workflow, which will be shared later on, to connect the patients to resources. And very quickly, I just wanted to share the cheat sheet that we created for our MES. If it's an easy BPA alert with just one code, then they can also use that. But oftentimes there are multiple codes showing up based on how the patient answered the questions. So we just created this cheat sheet with just one code for them to enter, and then pen the referral for the provider. So at this point, I'm just going to stop sharing.
That's great. Thank you. And before we continue, it's really wonderful to see, how it's done in action. I think it's one thing to hear you talking about it and how it works, but then to see the workflow, it's super helpful. Before we continue on with the conversation, I promise Jenna will give you some airtime. But before we continue on, I was just taking a look at the chat, and there's a few questions that I think are relevant to this conversation before we move on. And so Bernadette just had a question about the prepare tool. The prepare tool and the SDOH domain two different tools, or are they embedded in the same?
So the SDOH domains has all the questions that the prepare tool has, but it has three more questions. So it screens for more domains than just the prepare tool in Epic. So we just decided, because I feel like we like all of the icons to be addressed in the storyboard and all of the domains to be addressed. So we are just following the SDOH domain or all SDOH domains tool in Epic, which includes the prepare questions.
That's great. Thank you. And then just a quick question about Z code reimbursements. So we know they're not currently being reimbursed. So can you just talk about what strategies BACH has used and, any challenges? We'll talk about the challenges later, actually. So we'll just talk about any strategies for reimbursement.
Yes, so that's a good question. And, so right now, we are not getting reimbursed for any of the screenings that we complete or any of the care coordination that our CHWs are doing. I think as FQHCs, from what I have researched, it is only reimbursed for Medicare patients, and there is one code that they can use. I think it's it's G. There is a G code that can be used, but it is only if it's not just for universally screening anybody, but it's only if the provider has reason to believe that the SDOH needs interfere with the diagnosis and treatment for patients. So it's like, it's done for risk assessment, but only if the provider feels that it's necessary, and it has to be documented in the chart. And I think for Medicare, the code is G0136, and it can be done once every 6 months. But as a standalone screening, if anybody does it, like CHWs do it, or if it's done, just for universal screening, I don't think there is reimbursement yet for FQHCs, but hopefully, we can advocate for it. But the other way that we could get reimbursed is if we partner with a CBO who is able to be reimbursed for SDOH screenings and care coordination. So we are exploring that option. So there is a vendor or a company called PairSuite that we have decided to partner with, and they already have one of our South plans, Santa Clara Family Health Plan, that they have an agreement with for reimbursements. But we are trying to, and they're trying to outreach the other health plans. So hopefully there will be reimbursements, with that route. But that is a big need, I think, for sustainability is, having more advocacy for reimbursements for the time and for the effort that we are putting in.
Yeah, absolutely. Well, thank you so much, and keep the questions coming. We'll integrate them as we continue on with this conversation. So I want to talk a little bit now about the referral piece. So Jenna, can you just share how BACH streamlined the social care referrals to CBOs through Find Help?
Yeah, so Dr. Menezes spoke a lot about our Find Help resource, and this is really the tool that we are using to streamline these referrals. We found it's very useful because it is a centralized hub, if you will, and you can customize the services that show up as a result of your search based on the patient's zip code and what their indicated needs are. So it's a very user-friendly platform. So we've trained our CHWs, our CPSPs, which work with our OB population, and our medical assistants and our nurses to use this resource to help connect patients with the resources that they need in their areas. And this process in our medical clinics heavily relies on our CHWs, but the reason we've also integrated our CPSPs, MAs, and nurses is because they interact with patients at different times during their care. And so CPSPs are seeing patients in individual appointments, and as much real-time information as we can give patients, we find that it's most successful. So in turn, that gives medical assistants also the opportunity, if we have a patient kind of with an urgent need and the MA has the capacity to do and have that conversation real time, they're able to do that as well. Where our CHWs catch it on the back end in the form of a work queue, who can then call the patient and take a little bit more time to explain with them, what this resource is, what we're going to find for them, and then either email or verbally give them the information of the community organization that we found that might be able to serve them. So just talking through the workflow quickly. Basically, when a patient screens positive on the SDOH screening, the provider can just speak to them a little bit, acknowledge that they've received the results of their survey, and say, I'm going to place a referral for you. Someone will be calling to follow up with some resources that might be able to help you. And that referral goes directly into the work queue Dr. Menezes spoke about earlier. Our CHWs then are calling patients and discussing a little bit more about their survey results and what types of services might be most helpful to them. I'm going to quickly just share our workflow with you all from the Find Help side. And this will be brief, but this is what it looks like within Epic. And so it is linked to our patients' chart directly. So we launch this, we go ahead and we put in, the the issue or the hardship that the patient might be facing. And then it gives us, we can filter it by programs, income eligibility, and then we'll also input, it already has the patient's demographic information. So based on their demographic information in Epic, it will then come up with some resources that are available. You can click refer next to an identified program that might help, or apply and next step. So there's some dependency on the organization, you know, if they take referrals directly from this program and they'll call the patient to follow up. But it also may say, you know, here is how we get in touch with the organization, and we would give the patient that information. And I'll stop and see if there's just any questions at this point. Doesn't look like it. Okay, great. So I'll go ahead and continue. Yeah, so I mean, just as Dr. Menezes said, we piloted in one clinic with 2 providers right now to really nail down this workflow, and be able to make sure that we're doing the right things by patients. If we're screening them, we want to help them. And so before we say, you know, we want everyone to do this, we really need to make sure that we have a tight process that we're comfortable expanding so that we're not leaving patients screened without follow-up here.
Great, thank you. Yeah, and before we kind of move into the closing of this conversation, just the one question popped up about how do you track outcomes from your referrals?
Yeah, I think this is a gap in our process, and I think as we continue to build, what, you know, I was speaking with Dr. Menezes about earlier, and this kind of I'll speak a little bit more about it later, but we don't have a super robust resource to be able to care manage these patients and case manage these patients outside of their primary care visits. So this is all documented in the EMR, and the next time they come in and see their provider, it can certainly be discussed. You know, hey, did you have a chance to connect with the food bank? Are you getting the food that you need? And kind of that type of check-in. But at this time, unfortunately, we just don't have the resources to do the follow-up calls and say, hey, did you have any trouble? Did you get this? So it really puts the impetus on the patient at this point. We're providing the resource, but we would love to have the resource to be able to call back and say, did you get it? Do you need my help filling out paperwork? You know, yeah. So hopefully maybe in the future, depending on what funding looks like.
Yeah, absolutely. Yeah, and this is actually a really good segue, I think, into the last part of our conversation today, which is really around, you know, the barriers and successes you've had with this project. And so would love to hear, you know, what are the top 3 barriers that you encountered, and what are the top 3 successes that you encountered with this work?
Yeah, so I think initially our barriers were IT driven. We had some issues with inconsistencies of the answers flowing into the chart. The patient, you know, may complete the survey on a tablet and we didn't see them in the chart. So then, you know, do we need to ask the patient to complete on paper? Do we need to just have a conversation with the patient in person? So we were working on fixing kind of the connection issue, and then we had some issues with our tablet functionality. So tablets freezing, not charged, lack of enough tablets. So working to kind of mitigate those issues on a basic IT level was helpful. And then also the consistent use by the front and back office, you know, just making sure the front desk truly is seeing the icon on the DAR and saying, hey, you have a survey, being able to explain what the survey is and why we're doing it, and making sure the patient then completes the survey all the way through. And what we found to kind of mitigate that was we actually brought the tablets to the back office. We had started with them in the front, we brought them to the back, and having the MAs be kind of the gatekeepers in the process and kick it off, they were better able to track the flow of the visit and the patient filling out this survey prior to the discussion with the provider. And we found better success with moving the tablets to the back office. I think that, oh, and then, you know, it's a new process. So every time you have something new, you know, getting everyone on the same page. We mentioned before the management of multiple codes was a hard thing. So we made a cheat sheet in response. And so I think just going piece by piece and really trying to get everybody on board on the same page. And then our facilitators of implementation that, things that helped us really be successful here, were organizational support. So as an organization, BACH supported this initiative. We had support from our leadership team, from our different stakeholder departments, our ITIS team, our operations team, our clinical team. And that's just so integral in any type of new process that is such a huge lift, that we have that support to be able to say, hey, I need help. Hey, this isn't working. This is what we want to do. And then also having champions within the clinic. So the two providers, Dr. Menezes is too modest. She is one of them. And then one of our clinic supervisors have really been, all in on this project and taking feedback from staff, from patients. Our clinic supervisor is the one that's working with the MAs to say this is working, this isn't working. Developing a lot of our cheat sheets and things like that. And that's been really great. And then just their flexibility to be able to make changes and, understand it's a new process and kind of mitigate frustration that way by saying we're learning through doing, and everybody be on board to do that. So I think those are the three things that have really enabled us to be successful up to this point.
That's great. It's really, really exciting work, and kudos to the two providers that are helping to pilot this. So before we bring Kush back into the conversation and kind of open it up for Q&A, I'd just love to hear what's next with this work. Where are you going next?
Yes. So, Jenna, you want to take that?
You can
Okay,
bet.
I
No
can start. Yeah. So I wanted to share that, yes. So first and foremost, we are looking to scale this work. Have more providers screening patients, educating and gaining provider and staff buy-in. We have had some huddles and discussed about importance of SDOH screenings and health outcomes and correlations during our previous huddles, but we plan to do more of it in 2025. And the other thing we are looking at is to create reports to track improvements and also to help us research, are these screenings correlating with improved health outcomes in our patients, especially because we do want to see if that is improving quality, and improving population health in the long run. The other thing that we are looking is to advocate for reimbursements from the health plan, and also to find like grants and some funding to help us with our current work that we are doing, especially we are looking to hire more CHWs. Our goal is to have at least 1 or 2 CHWs, doing this work in clinic at all of our locations. But currently, we are not there yet. We have hired a few, but it's just right now we are only at one site. But if we have to expand, we need more staffing. And we also are looking to hire or looking to involve other social services organizations and our especially the Alameda County Public Health Commission, maybe the Public Health Department, to share our data to see if that helps improve policies and programs. So yeah, that's some of the next steps that we are looking at.
That's it. So exciting.
Thank you. Jenna, do you want to add anything to that?
No, I think you pretty much covered it all. The last thing I would say is, further expansion of our staff and our team's understanding of SDOH and the correlation of health outcomes with addressing SDOH needs in patients. And I think that within the clinic that we're piloting this with, there's a large understanding, but we have a lot of work to do to educate, everybody else and just continue to build upon that knowledge base. And that'll in turn increase kind of the buy-in that we have to expand this project, and with everyone understanding the importance.
Great. Thank you so much, Reema and Jenna and Kush. We'll bring you back into the conversation as we open it up for questions for everyone. And so I have some questions in the chat, which I'll get to. We have time for about 2 or 3. But if you have a question and want to unmute yourself, just raise your hand. Be happy to call on you. So I think a quick, easy question that's up at the top is, and you may have mentioned this, Reema, but what modalities do you use for the SDOH screening? Is it just in person? You mentioned that they come in and it was at the front office, but do you also do other modalities for getting this screening?
Yes, so we do use MyChart for screenings. Patients could complete it prior to their appointment. And then we are currently screening patients who come into the clinic. We haven't yet started, tele screenings, and not all of our patients are on MyChart, so we are missing a lot of the patients. But right now, we are doing both MyChart as well as in clinic with the welcome tablet.
Thank you. And can you just talk a little bit about how this is, the positive screening is intersecting with CalAIM and community supports?
So right now, the positive screenings are being referred, to our community health workers, and they find resources on Find Help. The other resource that we use is Recipe for Health for food insecurity, but we do not currently use, other community support, through CalAIM. I'm not sure if some of those CBOs or, community support organizations are in Find Help. So we would have to look into that.
Great, thanks. Yeah, Kush, are you familiar or do you know of any other of your member health centers that are referring these through Find Help for community supports?
Yeah, I don't think we are. The issue is like Find Help. In order to like send a referral to a CBO through Find Help, like the CBO has to be enrolled. Like, so there needs to be like someone to accept the referral on the other side. I think there is like a alliance in Healdsburg. Like they had started this workflow where like instead of like like how BACH is like submitting a referral to a community health worker who then provides a phone number to call, they were actually like submitting the referrals directly to the CBO that was registered on Find Help. So it was sort of like a two-sided process. What they were finding was that one, like CBOs are not used to like using Epic or like not necessarily Epic, but like using these like electronic based referrals. Their workflows are sort of like very like phone or like patients coming in based. And so folks were not checking their inboxes very frequently. And so messages weren't going anywhere. And then also like there was no good way for the CBOs to say, hey, what, like we're at capacity, we can't accept this patient. Like they kind of kept on getting referrals. For Lily's question, I don't like the community supports through Alameda Alliance for Health are not integrated onto Find Help. So I think if like as the CBO is like Reema mentioned, like if they are, providing it, then we'd have to look into it. But I don't think the alliance is.
I just wanted to add to what Kush said is, we do have, if the patient is getting ECM services, so our CHWs will contact the CBOs and they will provide other community supports through the health plan, if they're aware of other resources. But most of our CHWs, use Find Help and they may not be aware of the other resources. So maybe we may have to look at as many, we could find and create a custom list in addition to Find Help. But right now, and the good thing is that, with Recipe for Health, we have an interface. So the referral can be placed in Epic, and we have a Epic workflow for Recipe for Health. So that's the other issue is that if we are referring to CDO, if it's like a paper workflow, it gets a little difficult and time consuming. But yeah, so most of the referrals right now are through Find Help. And yes, it's the onus is on the patient to call and schedule, that, or call and, make sure that they get the resources that they need. We right now do not have the bandwidth to, call the CBOs and make sure that, it's like bi-directional. But in the future, if there is a way in which we could improve that, connect with the CBO through Find Help, I don't think that's possible right now. So right now, we are mostly, giving the resources to the patients and hoping that they do connect with them.
That's great. Thank you so much. We are going to wrap up this conversation. Really appreciate this discussion over the last hour. For folks on the line, I'm just going to launch a poll. Please fill it out. It helps us understand how we can continue to provide useful content to folks who follow our newsletter and stay connected to the California Improvement Network. And I just want to send a huge thank you to Dr. Grewal from Community Health Center Network, to Dr. Menezes and Jenna from Bay Area Community Health. Really appreciate you spending the hour having this conversation, sharing the amazing work that you all are doing in your communities. So thank you, and thank you so much for folks who joined us today.